Okay, so let's start with sort of one of the overarching problems. Here in the United States, as I'm sure all of us have heard, our healthcare is very expensive, almost double that from other developed countries around the world. And what do we get for it? Well, it depends what measurement tool you use, but on many standard measures, our quality ratings are amongst the bottom of that same group. So that's a problem that we are trying to address in a variety of different ways, Affordable Care Act, and there's a lot of work in this area. Something that's a little less known is, and I brought my pointer, I love pointers, is when you look at the bottom, these are two bar graphs that are stacked up, and the dark blue is basically healthcare expenditures as a percent of GDP, and the light blue are expenditures on social services. So while indeed the United States spends quite a bit more on health expenditures, we spend quite a bit less on social services, or differently put, when you combine the two, we spend about the same as everybody else. So the question is, what are we doing? What's our strategy here? We're all complaining about people coming into the ER, people that are using healthcare services, quote, unnecessarily, people that have transportation problems, food problems, basic education problems, and it may well be that what's going on is that we've somewhat underinvested on the social services, and I'd go so far as to say the education side, and that we're catching the ball downstream. The effect of this is that our healthcare delivery organizations, what we're doing is we're pushing more risk and more responsibility on hospitals and health systems, and to some degree payer groups and ACOs. And so what they're doing today, what many of us are doing today, is trying to figure out, how do we address this piece? And so hospitals are hiring not just caseworkers, but social workers. Hospitals in the business of social work, and I'll bet anyone here who's in healthcare delivery is saying, you bet, we need them. And we need them because we haven't really taken care of this up front. So the opportunity to work together is very much alive, and in fact the alignment of financial interests and reimbursement are starting to build a business case for doing just that. If we look at the determinants of health, you can see that well over half of the determinants of health have to do with the people's lifestyle and the physical social environment in which they live. So we can talk all day long about efficiencies in our healthcare delivery, but we're only going to get so much efficiency there and so much improvement. So if we want to improve the health and quality of life of Americans, we've got to get at the bigger part of the pie. That happens outside of the walls of the hospital, and yet we're pushing financial responsibility onto the hospitals. And that dichotomy is what collectively we can begin to address. And it's going to take all of us, and not just the traditional institutions and those of us here, but really inspired leaders. I mean, anyone locally who's got great ideas and is sort of feeling the mojo can make real change, and we're going to hear great stories over the next couple of days. So here's a way that I look at this that might be helpful, because there's almost two sets of activities going on at the same time. One is what I call the inside out, and this is healthcare delivery, and I'm only mentioning this, it's maybe about a third of us in the room, but it's where a lot of money gets spent. And what's happening is that as we move towards something called population health, healthcare delivery organizations are looking at claims data and electronic medical record data, and they're stratifying their patients into risk groups, and then they're trying to create better care coordination and evidence-based guidelines to improve care and better outcomes and ideally lower costs. Okay? So that's starting with the patient in the hospital and working out. And they sort of are beginning to follow the patient home to get at these lifestyle issues, medication compliance, these kinds of things. On the other direction are maybe two-thirds of us in the room that are working out in the community. We look at different kinds of data typically. We look at public health and demographic data. We look at the evidence base of what's going on in different communities, and frankly, I work with communities all around the country. We're not very good about sharing what's working in different communities. We need to do a better job of that. And then we try and implement programs and measure impact, and that's real hard to do, but that's our work. And what's exciting is when you start putting these two together, we should be taking our quality initiatives in healthcare delivery, quality improvement, and aligning that with what we typically call our social or community health improvement work, and we'll get a force multiplier on the activity. So one way to think about this conceptually is that there's a lot of data out there. If you understand the data in your community, pockets of different problems, groups that have particular issues, once you understand the data, you can choose your priorities, you can implement ideally evidence-based programs and policies, and then build an evaluation framework to do that. In the interest of time, I was going to go online, but I think maybe later we'll have some opportunity and I'm going to show some technology. Let me give you an example of how this actually plays out in communities, and there are lots of these going on. So here's a group that we're working with in Hawaii, and it's starting with the hospital, but as you see in a minute, it's going to pull in all kinds of community players. And we were looking at the bottom line. Where are their costs, their highest costs for inpatient hospitalization? So inpatient hospitalization costs. And you can see that these 4 here that are highlighted all related to diabetes. So they've got about $8 or $9 million just associated with inpatient costs. This is not ER rates, this is not outpatient costs, and they're getting dinged. A lot of this is unreimbursed. So they said, help us out. What can we do? Help us connect some of these dots. So we looked at, this is Oahu, and we have something called a vulnerability index. So it's sort of, it's a score by zip code of where the highest vulnerable populations are, which leads to higher levels of hospitalization rates. So we identified some geographic targets. We overlaid this with basically patients that either have diabetes and or have already been hospitalized for diabetes. Those are the ones in red. And then we looked at what's called an asset map, those little stars. Where are the partnerships in the community? The hospital's way over here. But these can be places like churches, schools, barbershops, all kinds of places. These are potential venues for doing something, in this case around diabetes, but it could be any topic that you choose. And then looking at the evidence base out there, what's going on in different communities that really works, and among other things, found a program which has been, it's considered evidence-based, and we did some sort of modeling and found out that if they were to implement this program for about half of the patients that have diabetes in just their service area, they could save close to $20 million a year. Now, those are real numbers, and they're on the hook for some of that money. So now what they want to do is, who are the community partners that we can work with around this? So what's happening is very exciting as we begin to align these things and work together. So this is kind of a big picture view of the evolution of community health activities. I won't go through all of this, but it used to be that individual groups would work kind of narrowly on different things, and we've been sort of steadily working upstream over the last decade or two. People have really used to work more or less alone, their organization. Clearly, people are working much more in collaboration, like here, the North Jersey Health Collaborative. And so my recommendation, if you're not already doing this, is to align your work with some collaborative and make sure you're using a methodology, whichever you want, but something like collective impact seems to be very popular. And if you are mission-driven, also be data-driven. It's not an or, but be data-driven. There's a lot of data out there that's available. And instead of just doing the right thing, be evidence-based. There are a lot of programs and policies that are tried and true that are working out there. And instead of just working hard, build an evaluation framework. It's hard to do, but you can go out and do really, really good work, but if you don't measure it, then the problem is you don't really get the credit, and then you don't get more resources to grow it. So when you start your programs, you need to take a percentage of your effort and build an evaluation framework and measure something, ideally, that's aligned with what some other groups care about, and then it can grow, and you can celebrate those successes. These things in black are pretty much what I see going on around the country all over the place. These are what I posit are coming up. They're not really happening yet. One is that we need to start integrating the community-based activities with the clinical activities and get that force multiplier. And a second is we need to stop thinking about incremental change. It's not about somebody coming into the ER and figuring out how to process them in 12 minutes versus 15. It's about changing the way we provide services that can completely be, in a positive but disruptive way, more efficient ways of providing services and care. An example in San Francisco is when people are inebriated on the sidewalk, instead of taking them into San Francisco General, the old way, they take them into a different place called a sobering center, and they're saving $9 million a year by doing that one program. And these inebriates are getting better services. They re-engineered the process. So all of us need to work together to really build these adaptable communities. Well, let me close by saying this. There's an author up at Harvard, Gulati Ranjay, and he wrote a book, Reorganizing for Resilience, which I thought really fit the tone of this conference very well. And I obviously won't try and summarize his book, but he's got sort of the 5 C's, what any organization needs to do to be adaptive, to be resilient, and to make positive impact. And the first two, coordination and cooperation, are sort of things you do with people internal to your organization. And then he's got clout and capabilities, which basically says give more authority to the people out in the field that are working with your customers or your target population. But he says the most important by far are connections. And I'm just going to read this one excerpt where he says, the point where the greatest resilience is achieved is connection, shrinking the core, expanding the periphery to join seamlessly with external partners to identify and solve various problems. And when that's completed, then organizations achieve the shape-shifting holy grail of outside-in actions. And they achieve the responsiveness and nimbleness that will help them navigate even the most roughest of oceans. So we got a lot of inspiring people here today, and I think that the more we can connect those dots and align our financial interests, we have really wonderful things that we can do together. Thank you.